Ureteric reflex and UTI management guidelines. Vesico-ureteric reflex (VUR). Reflux of urine from bladder into ureter. Usually it's congenital. Pathogenesis. Ureter, it's opening in the, this has a submucosal tunnel, oblique insertion, short absent submucosal tunnel that will cause vesico-ureteric reflex. So normal it's an oblique submucosal tunnel, but here it's a short or absent submucosal tunnel. Inheritance is autosomal dominant. You have to screen siblings as well. Features: reflux from bladder, ureter, cholestasis, recurrent UTI, severe vesico-ureteric reflex. Kidneys causes scarring and reduced functioning. If bilateral, then chronic kidney diseases and hypertension can cause reflux nephropathy. Vesico-ureteric reflex, most common anomaly in a child with recurrent UTI. What is the most common anomaly in a child with recurrent UTI? It is vesico-ureteric reflex. Vesico-ureteric reflex plus bowel bladder dysfunction is due to increased severity of vesico-ureteric reflex and delay in resolution of vesico-ureteric reflex. Diagnostic: maturating cystourethrogram. Maturating cystourethrogram confirms diagnostic and can evaluate severity of disease, also known as voiding cystourethrogram. Retrograde flow of contrast in the kidneys. There is a retrograde flow of contrast in the kidneys in maturating cystourethrogram. Grading of vesico-ureteric reflex: grade 1, partial reflex; grade 2, complete reflux; grade 2 plus, associated dilatation of bladder and renal pelvis; grade 3, tortuosity of ureter; grade 4, distorted pelvic calyceal impressions. Distorted pelvic calyceal impressions. So there are 4 grades of vesico-ureteric reflex. Grade 1, you are seeing partial reflux. Grade 2, complete reflux reaching the kidneys. Grade 3, there is a dilatation of bladder and renal pelvis. Grade 3, the ureter is tortuous. Grade 4, there is the distorted pelvic calyceal impressions. Radionuclide cystogram for follow-up of vesico-ureteric reflex. Advantages: there is less radiation exposure. Disadvantage: accurate grading is not possible. Management: vesico-ureteric reflex resolves spontaneously. You have to give supportive management like adequate fluids, management of BBD by management of bowel bladder dysfunction by regular and complete voiding, relieve constipation if present. If there is a prevention of UTI, if UTI occurs after prophylaxis, post prophylaxis, it's called breakthrough UTI. Then you have to do surgical correction, ureteric reimplantation. Prevention of UTI. How do you prevent UTIs? Prophylactic antibiotics until bowel bladder dysfunction resolves. Indication: grade 3 to 4, 5 vesico-ureteric reflex in the last grades. Drugs: cotrimoxazole, nitrofurantoin, and cephalexin. Which drugs do you use for prophylaxis? Cotrimoxazole, nitrofurantoin, and cephalexin. Regimen: until 2 years of age or 1 year after last episode of UTI. Regimen: until 2 years of age and 1 year after last episode of UTI. UTI. Significance of UTI in children. Presentation: fever without a focus, especially in infants. Classification: simple and complicated. UTI in less than 5 years. Investigate for renal scarring and association with anomalies in urinary tract. Most common organism in UTI is E. coli. So what is the significance of UTI in children? Presentation: it's a fever without a focus, especially it's seen in infants. Classification: simple and complicated. UTI in less than 5-year-old. Investigate for renal scarring. Association with anomalies in urinary tract. Most common organism in UTI is E. coli. Definitions: complicated UTI and simple UTI and recurrent infections. Complicated UTI: there is a high grade fever that is more than 39 degrees Celsius, systemic toxicity, renal angle tenderness, and increased serum creatinine. When do you say it is complicated? When there is a high grade fever, systemic toxicity, renal angle tenderness, uh, increased serum creatinine. Simple UTI, you have a low grade fever, you have dysuria, increased urine frequency. Recurrent infections, more than 2 episodes of UTI, look for anomalies. Significant bacteriuria, urine culture is a definitive diagnosis of UTI. What is the definitive diagnosis of UTI? Urine culture. Assessment of significant bacteriuria by assessing colony factor unit. So method of collection: suprapubic aspiration, colony count more than 10:3, probability of infection 99%. Urethral catheterization, uh, colony count CFU per mils more than 10:4, probability of infection 95%. Midstream clean clutch unit more than 10:5, 90 to 95%. Colony forming unit, CFU means. Asymptomatic bacteria, significant bacteria without any symptoms and there is no treatment required. Leukocyturia, more than 10 WBCs per millimeter cube in uncentrifuged urine sample or more than 5 WBCs per high power field in centrifuged urine sample. Leukocyturia, more than 10 WBCs per millimeter cube in uncentrifuged urine sample or more than 5 WBC per high power field in centrifuged urine sample. Not diagnostic of UTI though. Management: antibiotic management. It requires hospitalization. Complicated UTI, young infants less than 3 months. Antibiotic management will require hospitalization in complicated UTI and it's seen more in young infants like less than 3 months. Duration of treatment: complicated UTI 10 to 14 days. You give for 2 weeks approximately third generation cephalosporin like ceftriaxone and cefotaxime. Third generation cephalosporin like ceftriaxone and cefotaxime, or aminoglycoside single dose daily like amikacin or gentamicin. So when you have a complicated UTI, you can give up to 2 weeks third generation cephalosporin like ceftriaxone, cefotaxime, aminoglycoside single daily dose, amikacin and gentamicin. Simple UTI 7 to 10 days, coamoxiclav and cefixime. Simple UTIs you give up to 1 week, coamoxiclav or cefixime. Coamoxiclav or cefixime. First episode of UTI. First episode of UTI, ultrasound KOB scanning test to assess for abnormalities and post void urine in bladder. First episode of UTI, ultrasound KOB scanning test to assess for abnormalities post void urine in bladder. There is a first episode of UTI and you have done ultrasound KOB, kidney ureter bladder scanning test to assess for abnormalities and post void urine in bladder. It could be normal or there could be an abnormality. Increased post void urine indicates obstructive cause that can cause recurrent UTI, non-E. coli UTI. Second is maturing cystourethrogram, 2 to 4 weeks post treatment due to active infection. So second investigation is maturing cystourethrogram, 2 to 4 weeks post treatment due to active infection. It could be either normal or there could be abnormalities seen. Abnormalities are Vesico ureteric reflex or posterior urethral wall. Then you can go for DMSA scan to detect renal scars. 4 to 6 months post treatment as inflammation due to UTI can mimic scarring. DMSA scan to detect renal scars. 4 to 6 months post treatment as inflammation due to UTI can mimic scarring. Congenital, we'll see congenital anomalies and hydrocephalus in next week.